Welcome, everybody, to today's webinar. Thank you for joining. We're going to give the audience just another minute or two to get connected on to the platform. Just give us another minute or two. I see some people joining. Welcome. As you join, we are giving the audience just another minute or two to join into the platform. Okay, I think we can get started. Thank you for joining us, everybody. We will get started. So today we're going to review the new Medicare rules for RPM, CCM, and PCM, what high-performing practices need to implement in 2026. So as we start the year, many of you are navigating how to implement and scale these programs in ways that are truly supportive, that truly support patient care without overwhelming your staff and your budgets. Today's session is designed to break down the new Medicare rules, what they mean, what a sustainable model looks like in the real world, and how organizations are operationalizing these programs in practice. To provide a real-world comprehensive view, we're excited to bring together two program leaders. Angela Orski is Senior Vice President of Value-Based Care and Clinical Integration at Prisma Health in Greenville, South Carolina. And Patricia Dixon is Director of Operations at Capital Cardiology Associates in Albany, New York. We're looking forward to this panel discussion with Angela and Patty. It's going to happen around midway through the webinar, and we're going to explore how these peers coming from different care settings are able to, a large health system and a high-performing specialty group are adapting their workflows to improve outcomes and performance through these programs. We're also joined by HealthSnap's co-founders who will provide guidance on the Medicare rules across these programs and share patient and financial outcomes from their work supporting care teams. Dr. Wesley Smith is Chief Science Officer, and he will walk us through program outcomes towards the end of today's session, and also some parts of the Medicare rules as well. And Samson Magid, CEO, will cover the Medicare updates and how successful remote patient management, chronic care management, and principal care management programs are designed. So now we will go into a little bit of housekeeping notes. On your screen, you see some buttons towards the bottom of your Zoom platform. One on the left-hand side you see is a chat button, and this is where you'll find a link to access the slides from today's presentation. You can download them from that link inside the chat button on the left side of the bottom of your screen. You'll see that link come through several times as people join the webinar. That link doesn't appear for them until they join the webinar, so we'll send it through as we see people join the webinar. And on the right bottom side of your screen, you'll see a Q&A button. And although the audience's cameras and mics are off for today's presentation, we do highly encourage your questions to our speakers and panelists. And you can type those questions in that Q&A box, and we will answer all those questions live at the end of today's session. Okay. And with that, I want to welcome Samson on. Samson, if you can drive us through the updates in the Medicare rules. Thanks for joining us.
Absolutely. Thank you so much, Claudia, for the introduction here. Good afternoon, everyone. As Claudia mentioned, my name is Samson Magid. I'm one of the co-founders and the CEO of HealthSnap, and I cannot be more excited to share more about the really exciting changes and regulatory tailwinds that the remote care management space as a whole is starting to benefit from in 2026. Before we go into what the changes are, I'd love to just start with orienting everyone around what are the remote care management programs that we're going to discuss today. And as Claudia mentioned, we're going to hear firsthand from two leaders from a very large private cardiology group and then a large clinically integrated network, Prisma Health, and their experiences implementing and scaling these programs in a clinically integrated way. So we're going to go through one, what is remote patient monitoring or remote physiological monitoring at a high level overview. two, principal care management, and then the third one is chronic care management, and how those programs all work together within a really scalable and long-term sustainable care management program that drives clinical ROI and financial ROI for your organizations. So we'll go ahead and get started and give an overview of remote patient monitoring or remote physiological monitoring. At its core, this is designed to be a disease-specific monitoring and management program where you are monitoring peripherals remotely and asynchronously from a patient's home. So if a patient, as a really simple example, has uncontrolled hypertension, you would then be able to monitor that patient's blood pressure readings through a connected device. It cannot be manually submitted through an application or submitted in a text, the reading. It needs to be electronically transmitted from a FDA cleared medical device. So really important nuance there that you can't get heart rate readings from an Apple Watch, for example. That is not compliant. It all needs to be coming from an FDA cleared medical device and connected from that device directly as the data transmits electronically. So the idea here is that you're able to either do this in a post-discharge readmit reduction model or an ambulatory longitudinal management model when it comes to improvement in health outcomes. And as you can see, depending on the patient's chronic condition or acute condition that we're monitoring, you can enroll them in a remote physiological monitoring program for one or multiple peripheral states and physiological readings, ranging from blood pressure to heart rate monitoring to blood glucose to O2 sats to weight, etc. Each of those are, provided again through a connected device. They will have to be transmitted electronically. The nuance for remote physiological monitoring is that typically you're going to enroll a patient in a program for one peripheral at a time because there is not expanded reimbursement for monitoring multiple data points at once. So when it comes to sustainability of the program and the economics, we typically see that a patient is enrolled for uncontrolled hypertension management as their reason for enrollment. They would get a connected blood pressure cuff. In the case of HealthSnap's program, those blood pressure cuffs, for example, are cellular enabled and pre-configured. So for a lower tech literate population that doesn't have a smartphone, they might not even have Wi-Fi or access to Wi-Fi in their home due to socioeconomic reasons. That device itself will have a cellular chip embedded in it and be able to just start taking readings and then send electronically with no setup required. And that would go the same for any cellular enabled device, whether it's for a blood pressure cuff, an O2 set, a pulse oximeter, a weight scale, or a cellular glucometer. So again, you're monitoring vital signs. If readings are out of range, you're coordinating care and you're proactively intervening before a critical health event occurs to reduce utilization and improve outcomes for that patient with overall lower costs of care. So that's the overview of remote monitoring. What we see really commonly and the most impactful when it comes to clinical outcomes that Dr. Smith will share is that when you dual enroll patients in remote physiological monitoring, and then if you go to the next slide into principal care management or chronic care management, you get expanded benefit. So before I go into those additional care management programs, what changed for RPM in 2026? For the first time in 5 years, or now 6 years, since the RPM codes were unbundled in 2019, and expanded in 2020, we're seeing two major changes happening. Number one, reimbursement has increased in 2026 by an average of nearly 10% across all of the CPT codes for RPM and chronic care management and PCM. But for the first time since 2020, there's been two new CPT codes created for remote patient monitoring. If anyone is familiar with RPM, you know that you need to take 16 readings in a 30-day period to bill for a data transmission code. CMS is now created based on the clinical evidence that if a patient takes 2 to 15 days of readings, you can now bill CPT code 99445. And if a patient has 10 to 90 minutes of physiological clinical staff time for their care documented, you can now bill 99470. These two codes, one, create flexibility based on clinical evidence. If a patient does not need to take more than 16 readings in a 30-day period, you can now bill appropriately based on the medical necessity for that patient. A really good example is a weight loss program where you might not want a patient to take their weight reading every other day or every day, but maybe once a week or twice a week. You now have the flexibility to expand the clinical use cases based on these new CPT codes that were created Same thing with the 20-minute requirement prior for CPT code 99457. You now have a more flexibility with a 10 to 19-minute CPT code for RPM. So those are the two big changes for RPM with the two new codes and reimbursement expansion. As we move to the next slide, just at a high level overview, principal care management is a disease specific care management program. So you have a disease specific care plan created for a patient. This is, common in specialists like cardiology. We also see chronic care management as well, depending on the regions and aptitude. But principal care management is a disease specific care management program for patients that have a condition expected to last for at least 3 months. And you can see on the right what the CPT codes are for principal care management. And I'll give it a broader overview, and you have access to these slides as well. But for the sake of time, we'll move through to the next slide, which is chronic care management. So similar to principal care management, it is a care management program designed to coordinate care more proactively and between office visits. Different than principal care management, though, is that CCM is a general care management program. So, meaning a patient would have two or more diagnosed chronic conditions expected to last 12 months or until end of life. And it is designed to be a more general, ongoing care management program and care plan delivered to those patients. So, principal care management is billed in 30-minute increments. Chronic care management is billed in 20-minute increments of clinical staff time. You can go to the next slide. And then, as I mentioned prior, you can see this is an overview of each of the RPM, chronic care management, and principal care management CPT codes and descriptors and the associated work RVUs. Just to call out again, we're seeing meaningful reimbursement increase for the first time since 2020. You can see on the far two right columns the dollar change and the percent change at the code level. If you blend the percent increase across every CPT code for RPM, CCM, and PCM, we're seeing a nearly 9% increase across all the codes, with some of them exceeding 10% increase year over year from 25 to 26. These are the Medicare national averages, so we can certainly look up your specific MAC localities depending on where you're calling in from, as those rates may change up or down. But this is the Medicare national average and is effective as of January 1st of 2026. So our partners are already seeing the expanded reimbursement impact when it comes to their bottom lines with these programs, as well as the increased flexibility with the two new codes for RPM. With that, I know there's a lot in one. We'll definitely share more in terms of real world applications, but I'm going to pass to Dr. Smith to give an overview of some of the new Medicare value-based programs that have been announced that you all may be aware of, and just some perspective around how that fits into the fold when it comes to care management programs like RPM, CCM, and PCM.
Thank you, Samson. This program here, this Medicare Access Program, is one that we're all very excited about, based largely on how remote management of patients has led to some significant clinical ROI. It's called the Access Program. It's scheduled to start this summer. And it's focused on these four major tracks where, again, the clinical ROI has been extremely impressive. The overall clinical efficacy and the outcomes have shown that in these specific areas, like primary prevention of cardiovascular, renal, and metabolic disease, as well as secondary prevention of these conditions, as well as chronic pain, musculoskeletal pain, patient-reported outcomes there improving, and functional capacity and ADLs improving, and behavioral health. Medicare is setting up a model where the payments will be focused on the outcomes. So instead of paying for traditional fee-for-service like billing units, these payments will be on the outcomes themselves. So if a physician using a remote tech-enabled style of care to manage these patients can show proven outcomes, then there'll be reimbursement aligned with that. Now, what it's not is it's not going to be payments on top of the traditional fee-for-service payments, but it is similar to a value-based model. And if we go to the next slide, there's a little bit more on what will be looked at and what will be paid. So we can go to the next slide. So it does allow for a little more creativity since it's primarily focused just on the patient's outcomes. And there's no billable kind of time units. If a patient's already been talked to about physical activity and nutrition, other elements of their care plan to combine with their conventional care, then maybe the call doesn't have to be as long, the reach out, or maybe it's more of a digital relationship that's established with the patient. But the bottom line is the goal is to show these proven clinical outcomes, such as vitals, labs, the device data, patient-reported outcomes. And if you show improvements, audit-ready clinical outcomes, there'll be a payment associated with that. And it makes sense because when you look at the costs associated with remotely monitoring a patient, there have been sub-studies to suggest that you can remotely monitor a patient for about 50 years for the cost of an ambulance ride and a few days in the hospital. So again, we're very excited about this. It's coming out in July. There'll be more information specific to the reimbursement structure, but it'll be paying for improving patient overall outcomes rather than for just for traditional fee-for-service structure billing.
Wonderful. Thank you, Dr. Smith, and thank you, Samson, for those updates. And going through the nuances is really the critical part to understand what the impact of the changes are and how to navigate them. So now I'd like to shift into our panel discussion. Hi, Patty and Angela. Thank you for joining us today. Angela Orski, as a reminder, is with Prisma Health, SVP of Value-Based Care and Clinical Integration, and Patricia Dixon is Director of Operations at Capital Cardiology. Samson, welcome. You're welcome to join us, and Dr. Smith as well to chime in. I do have some questions ready for Angela and Patty as well. So Angela, Patty, I'd love to just start with the beginning, how you chose to start these programs, what implementation looked like, where you are today, and where do you see this changing in the next year or two? Just to get our conversation started, let's start with the beginning. Angela, I'll start with you.
Well, hello, good morning or good afternoon, depending on your time zone from beautiful Greenville, South Carolina. Excited to talk about the partnership that we've had with HealthSnap, because it's been a 4-year partnership. So we've got a lot of foundation that we can speak to around what has worked well, maybe what has been challenges as we work through our expansion, because we've gone from small to large in a 4-year period. And so I'll tell you a little bit about Prisma Health, just size-wise, because then it helps you determine why we ventured on this journey and why I think we are sitting with what I consider to be really large numbers of remote patient monitoring. So we've grown in the last few years to be the largest healthcare system, not-for-profit in South Carolina, expanded within the last year or so in the Eastern Tennessee market. But we've been a clinically integrated network with an ACO and heavy participation in MSSP for years. So we have well over 600,000 covered lives. There's probably 17 to 18 different contracts across the board. So a lot of innovation and a lot of focus around overall care management, bending the cost curve, being innovative in some of our care modeling. So about 5 years ago, one of our really large internal medicine groups certainly felt like there was value in remote patient monitoring. I don't think any of us are naive that there is value in that. But then what does that look like? And what does it look like with a large health system? We have over 433 physician practices. And when you look at even just on the primary care side for us, that's 50 to 60 locations that we were looking at. How do we initiate remote patient monitoring and expand our care management programs? Worked with a vendor or a partner, and we were happy with the 50 people that we were care managing and remote patient monitoring at that time. But we ran into challenges that we weren't finding at that time being solvable through our vendor partnership. And creating seamless clinician workflows was paramount to our physicians. They weren't going to adopt the program if we had disruption in their clinical workflows. Logistics support, handing out devices in a physician's office is just not manageable from many levels when you're looking at productivity and the flow of your patients. Compliance is a big risk for a large health system or for anyone, but there's a lot of compliance components. And then, of course, the billing rev cycle. We had to have an economic model that supported us. So meeting Samson and his group about 4 years ago, they brought to us not just the knowledge and awareness of actual integration and having the tools, but they also brought the skill set to actually do the integration. And that's what we were missing. It always was more one-sided for us as a health system to solve for all of the issues. We didn't have the partner who could help us connect the dots. And so I don't know, Samson, it was maybe less than 6 months, I think, from start to finish. that from the time we worked on our contractual agreement, that we did our education, we worked on our clinical parameters, we worked on the Epic integration. Now, it was fast and furious on our end to try to help, build uniquely what we needed on our side, but working side by side with our HealthSnap partners, we were able to fast forward that. And 4 years later, we've seen over 7,000 patients. I think I'm pretty comfortable with that number. It was 6,700 the last time I checked it almost a year ago. So over 7,000 patients have participated in a program with us. And we're over 8,000 programs per month. And so we're in over 50 practices, and we have over 300, about 340 of our physicians who are actually participating in the program. So it's hardwired, it's sustainable. We can talk later about some of the clinical outcomes and the successes that we've had, but from a starting perspective, that was our why. That's how we've been able to scale the program where our outcomes are today relative to volumes. And of course, we continue to see, when you ask about future state, continuing to optimize, celebrate what's being recognized at the federal level from a reimbursement perspective, continue to demonstrate. We've worked with HealthSnap to share our outcomes and our data, even on the cost basis, so that we can use that as leverage to educate at the federal level around the successes that we're actually seeing at the grassroots level with our patients and our panels. So look forward to continuing to advocate for that and see us grow this and see other payers continue to adopt as they see the ROI and the clinical and the financial benefits for our patient population.
It's been a busy few years. That is gigantic growth in a few years, and great for your patients in your area. Patricia, I'd love to hear your story also of how you got started and where we are today.
Well, thank you for having me, and you can call me Patty. I work for a private cardiology practice in upstate New York. We have approximately about 35, 36 cardiologists with a plethora of advanced practice providers. And we became invested in remote patient monitoring and principal care management after recognizing how many of our patients are going to benefit from closer monitoring and coordinated care, particularly those that often couldn't reach, that we could reach before clinical crisis. So as our patient volumes continue to grow, not nearly as high as Prism's Health, but for private practice, I feel pretty proud of our patient volume. The staff burden became evident, and our traditional visit-based care alone wasn't always as timely as our providers wanted them to be. So RPM and PCM have allowed us to intervene earlier and support our care teams more effectively and deliver care more consistently. So we've been involved in these programs for many years, the last two with HealthSnap, with a continued focus on appropriate selection, clinical relevance, and outcomes that matter both to patients and our providers. Today, we have over 4,000 patients enrolled, with RPM and PCM primarily supporting our heart failure, hypertension, and our cardiometabolic populations.
Fantastic. And I love, it's such an important part of this, and where questions really lie is the impact on the care team. And you spoke to that a little bit, Patty. So I'd love to go there next, the impact on your care team, your operations through these programs. What have RPM, CCM, and PCM had? What impact have they had on your organization clinically and operationally? And how do you anticipate the 2026 Medicare updates affecting your workflow or program design? We'll just go back to Angela.
So if we look at, there's been a lot of outcomes. And so I can do some really large scale examples, but I also don't want to overlook some of the smaller clinical examples that we've had. So thinking about South Carolina, there's a large rural component of services that we provide. And so we have a large outreach in areas where routine connection with our patients is limited. So we certainly have seen an incredible amount of clinical improvement and outcomes on the RPM side, but you tether that to the care management side and the component of bringing in a combined care manager who is assigned to that patient. Most of them are local to South Carolina. They know they get familiar with the practices. They're assigned to the practice. They get familiar with the physicians, their workflows. we've been able to not only what we feel drive adherence and patient activation through our partnership with HealthSnap, but we've been able to assist our physicians in providing a more clinical use case for how they manage their hypertension, for example. So part of our integration was all of our clinical notes are embedded real time into Epic, and they're also summarized. So if we think about the scenario where a patient would come into the practice, bring in a napkin with or a piece of paper with all of their blood pressure readings, and you're trying to decipher, well, how have they been over the last 90 days since we've seen them? We built something very unique where that is summarized so that the physician can see over time how has the patient been performing at home, and then they can make them appropriate medication adjustments. It's just not reacting to blood pressure up or blood pressure down in the practice. So that has really been a game changer for our clinicians, is having that line of sight into performance over a long period of time at home. But we've also seen the patients that are improving their engagement because they have a care manager that is collaborating with them, educating them. If they're not completing their readings, they're calling them to determine what are some of their barriers to success. So the activation has just been phenomenal. We've also had wonderful examples where through our interaction, we've been able to do immediate interventions. We're able to bring patients back into our practices more real time. Versus ED visits or urgent care visits, as our team is navigating with the care managers or where there are readings that are being escalated. We have escalation pathways, and we can see our patients in real time in our practices. We know we've saved lives. We've had several examples of patients who might have been having active stroke signs, and the clinicians have been able to intervene and get them immediate treatment. During, post COVID, we had a few folks, early into the season that were still having some COVID symptoms, and we treated a husband and a wife immediately. So we see it very grassroots. We see patient activation and success. We see happiness and contentment around the workflows themselves. The engagement from our physicians has been absolutely amazing. And they've seen the tools help them do a better job of medically managing our patients. And then, of course, we can talk, and I know Wes may have some numbers, but we're also seeing a significant improvement in some of our costs as well, too. And we've demonstrated that in some case studies and some analysis of our ability to do about a 31% reduction in our total cost of care for our high cost patients by wrapping these services singularly around them and doing a better job of managing them more real time and longitudinally in the home setting.
Any anticipated changes with the new rules, transmission, time requirements, anything like that?
Well, we're already seeing about an 8% improvement in our ability to bill for the services with the two new codes that we didn't have before. And so you recognize there's still a lot of work that's going into these patients in which our clinicians in the practice have not been able to get reimbursed. So coming out of the gate, our first month, it was a nice surprise to see that we're seeing some positivity from that perspective. And that we're able to, really right-size some of the opportunities that we're seeing around the billing from just those two new codes being added.
Going back to Samson and Dr. Smith's update, it really illustrates the opportunity for scaling these programs with more expanded opportunity this year. Samson, did you want to add something there?
I was going to just add, I think also reaffirms that the clinical ROI and evidence that organizations like Prisma and CCA are demonstrating at the scale they're at is being shared directly with CMS, and HealthSnap's really proud to be able to work with CMS and regulators when it comes to these types of programs and the evolutions and expansions of them over time. So, the lobbying efforts are starting to see, we're reaping the benefits of that, I think, as we move into 26, and expect that to continue as we continue to, publish with our partners over time.
And we'll be sharing that with the Madaxon community as well. Patricia, what impact have RPM, CCM, and PCM had on your organization clinically and operationally? And how do you see that these changes impacting your organization?
I feel like the impact of these programs on our organization has helped us maintain optimal patient care without burdening our staff. I think it's important to realize that, to piggyback on what Angela said, those patients coming in with the blood pressure on the napkins all the time, or sending in all of the cardio readings from remotely, these are the patients that we want to enroll in the program so that we can take care of them first and foremost. But I wanted to go back a little bit, if you don't mind, just to the care management aspect of it, because I feel that when Angela was talking, that the care managers and the partnership with HealthSnap have really been an extension of Capital Cardiology, and they are our patients' first line of contact. And like Angela said, the escalations and the workflows that have been worked on in a team approach between CCA and HealthSnap and have evolved and continue to evolve over the time that we partner together has definitely been beneficial to our patients and to our providers. It allows our physicians and nurses internally to be brought on board when the escalation deems necessary. So it's been a very positive impact, because I feel that trying to implement or scale these programs internally on your own can pose a lot of difficulties, honestly, in sustainability.
Absolutely. There's only so many care navigators we have in our teams.
That's right.
So that is a major support system there.
And then to talk about the impact that it's had on us, I really feel that we're able to provide better continuity of care between visits and more engagement. And I also feel that the patients are having more ownership of their health. And I think that is extremely important.
Right. Dr. Smith, did you have something to add there? I saw you unmuted.
Yeah, Patty actually said exactly what I was going to mention, and both Patty and Angela refer to this, but it's really HealthSnap had made a major focus to make sure that we didn't come across to the patients as a third party. We wanted to be an extension of their practice. We wanted to establish that continuity of care. And I know one thing physicians would be worried about, or maybe reluctant to get into RPM for, is they might think that their care of the patient might be replaced. And we wanted to do anything but that. So when we survey patients about what they feel are the major contributors to why their outcomes are improving, whether it be their blood sugar, or whether it be a heart failure patient that is suddenly triggering far fewer alerts and is more clinically stable, what we hear is they feel more connected to their physician, actually. And there's a sense of accountability, unlike keeping their own log and coming in as the example of, on their napkin with all their blood pressure readings that they took manually. They know that the data is getting back to their care team and their physician, and that sense of accountability reminds them to take their medication regularly. It gives them, as they hear about trends in their data on a regular basis, it instills health literacy, as well as some self-efficacy. The patients feel like they have more control, and that improved connection with their provider, we think, goes a long way into these improved outcomes. It's very important to us to not be a third party, just to be an extension of a practice. And the patients see on the caller ID, they see their physician's caller ID from the health system, not a third party or a HealthSnap or a spam likely caller ID.
It's a human connection between the HealthSnap and the partner, as well as between the physician and the patient. It's a human connection.
Yep.
Great. So Angela and Patty, you've each built and scaled these programs in very different environments. I'd love to hear your challenges. Those are always some pieces that are very important to take away and learn from. Your challenges in scaling, and what changes did you see were necessary to be able to make the model sustainable? Angela, going back to you.
Thank you. Adoption, change management is always a component of rolling out something new and something to scale. So we, with a lot of thought, we opted to start with our largest, most complex medical group in order to begin our testing and our pilot, which meant a scale could not come until everyone felt comfortable with the workflows. And a large internal medicine group who very concerned about their workflow, very concerned about disruption to their practice, we had to spend a lot of time, and Health Snap had to be on site working at the elbow with some of our physician colleagues around what does this model need to look like and how do we build this in a way that is sustainable within your workflows. The last thing that they wanted to see was a system mandated tool and workflow that they may or may not have wanted to adopt. They're the physicians, they know the care of their patients. And so we had to start very grassroots level. We had to build it, get adoption and buy-in. And then we had to use and we chose a physician champion to be our spokesperson to really understand the model, to really believe in the adoption of technology, the value that comes to the patients and back to the health system. So we had to spend a lot of time educating our physicians, a lot of a roadshow, if you will, around the whys of doing this work. What was the value back to our providers? We bill through their provider number, so they were very conscientious around what that could look like from a vendor model. Because it was their provider number. And so a lot of education, a lot of time listening, using the physician champion. And then the next probably biggest challenge for us was ensuring we had the compliance component work through. HealthSnap has been an incredible partner in putting a lot of those checks and balances in place for us. But with a large health system like ours, this program was not going to be moved forward until we had all of our checks and balances in place from a compliance and billing perspective. And so getting all of that established took quite a bit of time from building that to scale, but it's hardwired. It's very compliant. As we grow, the compliance scales with it. So it was really the change management component that we had to work through in rolling out something as large as we were doing. We didn't go patient by patient. We took the patient panel list, each of the practices, and said, these are the patients that we want to enroll in bulk. And so we had to be very mindful that all things were well orchestrated and we had a good construct before we could begin rolling that out to our physician partners to give us the orders and be able to start enrolling our patients.
Great. Patty, how does that compare to your experience?
Believe it or not, it compares very closely. I firmly believe in physician champions. They are really the way for our practice to implement and work through any obstacles that might come our way. So we too focus a lot on that. Compliance as well was something that we really stayed focused on. And like Angela said, once all the ducks are in a row, things are going to follow through and it becomes easier. So very similar pathways between our organizations.
And I think, Claudia, just to add to that from both their perspective, we've implemented over 200 health system physician group partners over the last several years. And I think the two areas that are often overlooked is cybersecurity and making sure that your vendor partner has, at a minimum, SOC 2 compliant or ISO 1000, but ideally high trust certification when it comes to the policies and controls that they have in place, with PHI. And then the compliance piece that obviously both Patty and Angela mentioned when it comes to the actual documentation and the requirements that CMS expects in the documentation when you bill. And I think those are two areas that are often put it behind the scenes, but will come up to the front very quickly as you roll a program out. So those are just two, I think, words to the wise in terms of what we've seen, making sure that all facets of these programs, from clinical integration to the actual care delivery, but also the back office revenue cycle, compliance, security pieces are all, checked properly and diligence done properly.
What does the average implementation look like in terms of timeline?
Yeah, I mean, we've done as little as 3 to 4 weeks, and if you're doing a full-blown, enterprise Epic integration, as I would say 4 to 6 months with a full Epic integration on the higher end. But the heavy lifting is done on our end in terms of the implementation pieces. I think the change management side is really what it comes down to in terms of how do we align the clinical workflows that the practices and partners of ours are looking to achieve, and most importantly, iterating on those over time. And I think that's the part that a lot of organizations try to get perfect in the beginning when there's really not a perfect one size fits all. It's going to be iterative over time, and those workflows will adapt over time to the organizations that we roll out.
Perfect. We are getting close to time, so I'm going to jump through a couple questions here, and then I'd love to end with some outcomes. Those are very important. But as your programs have matured, Patty and Angela, What outcomes, just quickly, what I know Dr. Smith is going to walk us through some outcomes from programs, but from your experience, what outcomes have you seen impacted your organization the most? And that can be either a long-term financial sustainability outcome or a clinical outcome. I'd just love to hear what really stood out for you all. Angela.
Definitely the clinical outcomes, because it's been across the board. It is those who are early activating, those who've been in the program for a long period of time. I mean, Wes is going to break that down for you, but there was a period of time that we were questioning Wes to say, "Are you sure these numbers are right? You sure the outcomes are that good?" And so we've sliced and diced it multiple ways to really prove that with the right approach, pairing with care management, having the tools, having all of the information integrated into Epic, so the physician at the point of care can make exceptional clinical decision making. All of that pulled together just to show that there is 100% confidence that the improvement in overall hypertension for multiple populations, regardless of rural, socioeconomic, it just works. And it seems like magic, but it's just a combination of all the things that we've built collaboratively and all investing collectively to drive toward improvement.
Wonderful. Patty.
And to add to that, I feel we've had fewer surprise decompensations and stronger continuity care between the visits. Being able to have visibility into patients outside of our office allows us to intervene rather quickly and prevent acute events. But, Angela's right. The data on the blood pressure is just astounding. And I feel that is another way to be able to present and to maintain physician buy-in, is to be able to show that data to those providers on their patients, the impact programs like these have.
And we're about to go see some of those outcomes. Before we jump into those, I have one more question for you all. If you could give one piece of advice for your peers, for other leaders starting an RPM, CCM, PCM program, what would it be? Angela?
I'm going to be honest, is vendor partner selection. We've been down this road, the back and forth between vendors who feel like they can provide the service, but they really can't. I think part of our physicians' hesitation in the beginning was building that trust. And so demonstrating that it is a partner, not a vendor, that's coming to the table is really what has made this successful for us. Everything that we've asked for to meet our demands, if it's escalation pathways, if it's compliance, we've been able to adjust and build that uniquely. Without that level of success, we would have had physicians who no longer wanted to participate in the program and would have stopped using the services. So you have to know that has been just really a game changer for us relative to our ability to not just scale, but to sustain this over the last 4 years.
Mm-hmm. Patty?
I definitely agree with that as well. But I also want to add that you have to have that patient education component, right? Patients need to understand why they're enrolled in this program and why their provider feels it's beneficial and why the monthly copay is going to be better for them than being admitted to the hospital. And I think recognizing those achievements that the patients are making is also really important to maintaining their activity within the program.
Mm-hmm. That patient engagement, it goes beyond BP. Yes. Well, great. Dr. Smith, I'd love for you to walk us through some of those outcomes. And then I know we have a couple audience questions I'd love to get to at the very end, if that's all right.
Sounds great. So right before I get into the show Prisma blood pressure outcomes, and then I'll get into CCAs. Both they've
Great.
done an amazing job. But back to your question that you asked about some of the things that can help the program be successful from a science perspective, from a nerdy scientist perspective. One thing that I was shocked to see, that all of us on our science team was shocked to see, because we have 25 million blood pressure data points across approximately 100,000 patients, is that Medicare patients with chronic conditions tend to average an 11 to 12 point daily variation from day to day in their systolic pressure. And that's when they take blood pressure at the same time of day. There's nothing that apparently changes in terms of medication timing. It's just a day-to-day variability that is about 4 or 5 points more than what the literature had anticipated. So what that means is in the office, those occasional episodic visits, there might be things that aren't being caught. So another reason why the longitudinal management of these patients seems to be so effective, because they do have these major ups and downs. We even see a 5 to 7 point increase in blood pressure typically in the winter season, and we see about a 3 point drop in the summer. Changes in diet, physical activity, maybe vitamin D play into that. So the opportunity to use technology to longitudinally manage these patients, it makes sense scientifically. And it's one of the things I think that's gone a long way into making it successful too. And right here in this heat map, we're looking at Prisma patients specifically. Because of that day-to-day variability, we like to look at the first week that the patient was on the program, what their systolic pressure averaged. And you can see each row corresponds to that. So the bottom row would be patients that averaged in the 130 to 140 range. And the highest row up there would be patients that were the most, the high acuity hypertensive patients with over 160 systolic at baseline. And then each column represents how engaged they were. So 1 to 3 days a week would be column 1, all the way over to 6 to 7 days a week in the column on the third column on the right. And as you look at the green text that shows you the percent conversion to control, you can see there's a linear relationship between engagement and the percent to control for the most part in each one of these tiles. Of course, this is observational data, so a big part of that probably is the level of motivation of the individual patient. But you can also see the systolic and diastolic improvements. Like, let's go up to the 160 and higher group. When we look at their first week of blood pressure readings, they averaged over 160. The patients transmitting data 1 to 3 days a week averaged a 24-point systolic and an over 11-point diastolic improvement. And that's when we compared their most recent week of data transmission. So we're comparing a whole week to the first week to the last. But look at the patients that were most engaged, an amazing 37-point systolic improvement in this group and nearly 20-point diastolic improvement, which is why the mean arterial pressure was around 25. Overall, for all of the patients that were uncontrolled hypertensive in week 1 of starting the program, there was a 13-point systolic, about a 7-point diastolic improvement. When we go over to CCA's, and their heat map looks very similar to that, but wanted to share just the longitudinal data on patients that we followed for a year. And again, there are seasonal, variations. We do see some ups and downs over time, but you can see the systolic and diastolic changes, they continue. And we've even seen them, not even plateau until about 30 months. So patients, they do make a lot of improvements early on in the program, most likely because the data is being used by the physicians to drive clinical changes in the care plan and in the treatment. But then after that, it doesn't just completely level off. It continues over time to improve. Overall, you can see the uncontrolled patients at CCA averaged an 11-point systolic improvement and a 7-point diastolic improvement, with about 80% reducing their mean arterial pressure. Average time on the program, 421 days. And patients with stage 2 levels of systolic and diastolic readings at baseline, when we look at their first week, we compare that to their last week. It's a 22-point systolic improvement and an over 16-point diastolic improvement. Highly significant. These asterisks here might been some time since all of us have had stats class, but that means it's a p-value of 0.0001. There's a less than 1 in 10,000 chance that what we're seeing here is random. This is really obviously clinically meaningful and very statistically significant in terms of the improvements that we're seeing in the patients. Now, those improvements, as I mentioned, even as when Samson and I founded the company, we expected that the monitoring of blood pressure, the monitoring of body weight, the monitoring of blood sugar will help identify problems like hypertensive crisis, dysglycemic events, decompensation, heart failure patients. We expected that. These medicinal improvements here were actually surprising. And like I mentioned, when we asked patients what they attributed to, they often talk about that sense of accountability, that improved health literacy, and the self-efficacy. Now, they use different terminology, but basically that's what it seems to be based on surveying the patients. But this is an example of the proactive element of remote managing of patients, and that is identifying issues, having customized by each health system, a customized escalation plan, like Angela mentioned, for alerts to be responded to in a way that doesn't burden the health system. It reduces administrative burden when you have a point person that can take care of these. But nevertheless, we can see patients that triggered an alert in the first 10 days on the program. So, and that's the way we decided to look at this. If I was a patient and I transmitted data 30 times in month 1, and I transmitted data 10 times in month 12, then a reduction in alerts over time might just me being less engaged. So what we did is we looked at, for every 10 days of transmitting data, how many alerts were triggered by these patients. And you can see in this first 10-day bucket, patients were averaging almost 2 alerts across all of these different hypertension-related cardiovascular conditions and renal conditions. That's quickly fixed by about the 20th or 30th day of transmitting data on the program. And then we had 20 bins of 10 days of transmission, and we look at it over time. And we can see by the 200th day of transmitting data on the program, the number of alerts went down by 92%, which shows a remarkable improvement in clinical stability in these patients with hypertension-related disease. They're triggering far fewer alerts because they're being better managed. Same thing with heart failure patients. When we look at heart failure patients that triggered an alert in their first month, and we follow them out for a year, we see a 95% reduction in body weight related alerts among Prisma patients that had heart failure diagnosis. And the scale was being used to obviously detect decompensation for rapid weight gain or perhaps cardiac cachexia for weight loss. Nevertheless, those body weight related alerts go down dramatically. And then when we look at AFib patients and we look at the number of data transmissions where they had a tachycardic transmission, a resting heart rate over 100, you can see that these are months on the program. By month 6 on the program, there's about a 52% reduction in the number of heart rate transmissions that exceed 100. So overall, we're very proud of the opportunity to lean into the science. After all, we came from a medical school initiative where we were only research-based, and this was prior to us becoming a private company. So we lean into the science, and we were very excited to share these outcomes with CMS. But of course, what CMS was most interested in was the return on investment and the total cost of care, the utilization. So we partnered with Prisma, and this is an observational, but it's a retrospective study. This is not a study designed to lower cost. What we wanted to see is, do we have patients where we have about a year's worth of claims data and cost data prior to the RPM program, and then approximately about a year's worth of data after they started the RPM program? And we can annualize both and look to see if there was cost savings. And going in, of course, we had no idea whether there'd be cost savings or not. And we identified 589 patients that met this inclusion criteria, and the median total cost of care was reduced per patient by $14,000. The average cost of care reduction was about $12,000 per patient. Overall, in these 589 patients, there was a $6.3 million of net savings in that 1 year, mainly driven by fewer hospitalizations, fewer readmissions, and fewer ED visits. So obviously very excited about this. We feel that data like this that exists in the literature now has been something that has caused CMS to lean more heavily into this. And like I mentioned earlier, the Access program is sort of a value-based care form of remote patient management. And we do believe this is hopefully the future of healthcare based on clinical outcomes like this.
Those are some powerful outcomes. Thank you for that, especially seeing in a relatively short period of time those drops and then the Medicare part as well. Really powerful. We have 8 minutes left, and we do have some questions from the audience that I'd love to get to. I welcome all of you to turn your cameras on. I think these questions might be for a mix of you all. So I invite you all to chime in. One question is, curious if any analysis has been done to estimate the annual number of WRVUs generated by a HealthSnap patient who receives CCM and RPM, or PCM and RPM.
I can take a crack at that one. I see the question in there. It depends on the organization, of course, and what specialties were rolled out within, but the compliance of each of the programs themselves are all well over 75% on the low end, up to 80% plus on each of the codes themselves. So you would have to do some math on the work RVUs relative to that code conversion, and then obviously the volume of that rollout. So the size and quantity of those will all vary based on how much how the scale of the implementation, but you can expect 70% to 75% plus at the code level for each of them.
Great.
And for those, just as a side note, operationally, just for interest, as we looked at, because a lot of the work is managed through HealthSnap, we actually worked with our compliance team and did a fractional work RVU for our physicians and APPs who are participating in this model, because not all of the work sits at the practice level because there's some partnership perspective. So that was a way for us to financially and economically look at the total model when you're billing underneath the provider number.
Great. another question to anyone on the call, any experience or thoughts working with PPG technology for RPM, Samsung, FiberCheck, etc.?
We don't have direct experience, but we're aware of those technologies. Usually there are partner recommended opportunities, and we are device agnostic. So if there is a use case that makes sense and we have the opportunity to roll something out together, we typically are open to those discussions, and it's more about prioritization at that point. But we have not done that directly quite yet.
Great. And what tools and resources did you use to be able to measure patient success using the patient reading data? Example, Ursa, etc. Ursa? That's a new one for me. Dr. Smith, what tools and resources did you use to measure patient success?
Yeah, if I understand the question correctly, we get the it's de-identified observational data. We have a tool that we use called Databricks that pulls it in directly from our portal. And then we do statistical analysis with statistical software. We mainly use Prism. And one of the things that this has enabled us to do is, even though it is a limited data set, we can tie, for example, zip code to the patient outcomes and look to see from a socioeconomic status. We can predict socioeconomic status to see if the improvements are similar across different areas. We find that, like with diabetics, when we work in primary care, we find that as you'd expect in lower socioeconomic areas, the blood glucose is more poorly managed, but the improvement is greater in those areas. We see that blood pressure improvements and working with heart failure patients, that by having access to zip code and tying it to socioeconomic status, we find that those patients do just as well as the patients that are in more affluent areas of the country. So we believe that the access, the making healthcare more equitable and accessible is important, but we use traditional, statistical software, and then we'd have to, in order to put together our peer-reviewed publications and to present at conferences like we always focus on doing.
Patty, Angela, anything to add there on how you're gathering data? Not sure if there's something on your side. Okay. Patty, yeah. Great. Let's see. What other questions do we have? How did you get your physicians to buy into the program? Those physician champions can really be critical in the implementation and adoption of technology. So tell me a little bit about that. Angela, back to you.
I found a physician who believed in monitoring. They wanted to do it. They were looking for a solution. And again, one of our leading internal medicine physicians, very articulate, could understand the modeling, and had a lot of respect within the system. But he was eager. He was like, I want to do this. And so that became our partner. And he led the way, worked side by side at the elbow with his colleagues, would question them appropriately, professionally, but he also used the approach of they shared their own individual success, so their partners could see their success in their practice and begin to slowly adopt and roll into the program. So your late adopters could eventually roll in because he was able to share, this is what I'm seeing, this is my patient panel. HealthSnap helped us to provide some of that data set, and he could demonstrate what's working well for his patients.
Patty.
I think that Dr. Smith presenting our data to the physicians, like I said earlier, really makes a big difference for my providers. They makes them more eager to participate, seeing their patient improvements.
Mm-hmm.
Yeah, I think it helps when we mentioned, Samson mentions this a lot too. We, as I said earlier, we came out of academia. So we understand, especially from a medical school's perspective, physicians didn't go to school to monitor dashboards. They want to work with patients. So we sympathize with that, and we show them that this just enables them to be able to longitudinally care for their patients even more proactively. And the program actually started prior to remote patient monitoring CPT codes existing. It wasn't like these codes came out and we formed a company around them. We were already monitoring and working with patients remotely. And I think that authenticity is important, kind of knowing where physicians are coming from, understanding what maybe some of their concerns are. But when they see the outcomes and they understand the authenticity that we bring, and vendors in the space have for improving patient care, we think that makes a big difference.
That's a great way to conclude this webinar. I'd like to give Patty and Angela one last chance to add any last notes, and Samson.
No, just appreciate the opportunity to share. We're honored to be able to share our success. It really is impactful to our patients across South Carolina. Welcome, the opportunity to help support in the future. But best of luck to those who are actively engaging and are looking to go on this journey.
Patty, you got one question for you if you want to squeeze it in. What is the overall enrollment percentage for PCM? You're reading it. CCM compared to how many decline the program?
I think our for capital cardiology, I think that we have an excellent. I think it's closer to 80%. I think of people enrolled, and that's monitored. We monitor it monthly to see what's going on, and we want to know why patients are deciding to get out of the program so that we can address it across the board. So those things are beneficial as well.
Great. And any last thoughts from you, Patty?
No, thank you for having me. I love sharing our success with the programs and what we've learned.
Thank you. Samson?
Yeah, I'll just wrap by saying I appreciate everyone taking the time to learn more about remote care management programs and the success stories that both Patty and Angela have been able to lead with their own organizations. Ultimately, for us, we think that this is the gold standard when it comes to chronic disease management in the home, and is transforming care delivery from a reactive episodic model in the clinic to one that's proactive, ongoing, and in the home, and the use of technology to create better patient-provider relationships, improve outcomes, lower the cost of care with better quality is why we all do what we do. And we're really proud to be able to call CCM Prisma Health our partners longstanding. So appreciate everyone's time this afternoon. And if anyone has any questions, of course, you know where to find us through the MedAxion team or directly as well. We'll make ourselves available to answer any questions anyone might have.
There's an evaluation that will pop up right at the end of this webinar. Please feel free to answer those questions, and there is a space to submit any questions to them. I will direct those to them or connect you directly. So please do stay in touch. Thank you all. Thank you, Angela and Patty, for sharing your stories. Thank you, HealthSnap, for your partnership. We will conclude the webinar now. Appreciate it. Thank you.